Hello, everybody. My name is Annelies Zinkernagel. I'm an infectious disease specialist working at the University Hospital of Zurich in Switzerland. And it's my pleasure to introduce our first keynote speaker, Andrea Ammon, for the talk entitled Multifaceted Responses to COVID-19 in the EU. Andrea Ammon is the director of the ECDC and former deputy to the director and head of the Unit for Resource Management and Coordination. She joined ECDC as the head of surveillance unit in 2005, and this unit was responsible for developing the European surveillance system, implementing a long-term surveillance strategy for the European Union, and evaluating the dedicated surveillance networks. In addition, revising the EU case definitions and producing an annual epidemiological report on infectious diseases in the EU, which I'm sure you all know very well. Prior to joining the ECDC, Andrea Ammon served in several roles at the Robert Koch Institute in Berlin in Germany, where she maintained and further developed the German national surveillance systems, coordinated national outbreak response teams for current and emerging infections. So she's really the right and fantastic speaker for giving us an overview for the multifaceted responses to COVID-19 in the EU. Thank you very much, Andrea, for accepting this talk, and I'm looking forward to your presentation.
Yeah, thank you very much for the introduction and also the invitation. I unmute. Okay. So I hope you can see my screen. Okay. Anyway, yeah, I did. So, thank you for the invitation, as said, and for my talk today, I have selected some examples of areas where the response in the EU is particularly multifaceted, and also I'm trying to show our efforts how to streamline this, but also part of our other work. So these are the facets from our part of work that I would like to show, and I will go through these one by one. First, the epidemiological overview. Now, this represents the single most frequently asked question that I get nowadays: is there a second wave? Now you can say, well, it's a second wave, and then maybe you can call it another wave, and there will be a third or whatever. But fact is that we do see an increase right now. So in this slide, you show as you see in blue, the number of case notifications since the beginning, and in green, the number of death notifications since the beginning. Now you see that we had one peak in spring, and the death peak, the deaths peaked as well in spring. Now you see we have an increase in case notifications. However, the deaths remain low. Now, the question is, why is this? And I will come into this, but first I would like to show you the facets, because this is the EU picture. When we go to the single countries, we see very different pictures. So some of the countries indeed, no, this is the EU, have a second peak. Other countries have a second peak that is much bigger. Then we have countries that haven't had a real first peak. And then there are countries that now seem to stay on a low level. So the picture is, of course, similar to the deaths, the death notifications, and it shows that the overall EU trend is misleading, because the picture is much more heterogeneous between the countries. Now, if we go and look at how does it look within the countries, another layer of heterogeneity comes, because you see here depicted by the different colors, different levels of incidence within the countries. So the picture is different depending on whether you look at the EU, the countries, and in between the countries and within the countries. And that is also shown in the, when you look at the notification rate trend for 14 days, we do this. Even there, when we look at the trend in some countries, like especially, of course, in the bigger countries, there is a difference within the countries regarding the trend. So some parts are stable and some parts actually are increasing. That makes it, of course, very difficult to say, well, there is one European situation. It is not. This is why staying with the wave picture, it's more like this. I mean, there are bigger waves, but within you find smaller increases and heaps and lower. So that is what I want to show for the epidemiological situation. There are different facets in the EU countries. The second area that I want to present to you is assessment. So we have this situation, and there are other factors that we need to look at in order to assess the current situation. We cannot just look only at the increase in cases. One major determining factor for the interpretation is how much people or the countries test and whom they test, and what percentage of the tests turn out positive. When we go back at the beginning in March and April, you see at the beginning there were shortages of lab material and testing kits and personal protective equipment, and countries only tested those that came to the hospitals. Many countries did so, with the turnout that a large part was positive. Then testing materials became available, countries tested more people, the test numbers increased. But what you can see is that the testing, the percentage of tests positive decreased. And that means that if you have increasing numbers in a phase where you increase your tests, but there is a sinking or stable seropositivity, the increase in cases is mainly due to the increase in testing. Whereas what we see now, there is an increase in the positivity rate. Of course, still an increase in the testing, but now we would also attribute a part of this increase to increasing transmission. And again, I don't go into this now. It is, of course, different in the different countries. There is another part, because you may remember that the curve for the case notification and the death notification is now wide. And that has to do with the fact that during this first peak in March, April, you see here the dark parts of the bar. These are the older age groups. They had quite a considerable share in the number of cases. But now, over the period since then, they almost disappeared, meaning that most of the cases right now are in younger age groups that are less likely to display severe causes and less likely to die. Now you see there's an increase, which means that, of course, if the transmission in the community is increasing, there might be a point where the screening and shielding of vulnerable groups will not function anymore. And if we don't curb this now here, it might happen that we see something like this case or age distribution of cases in the future, and then the death may also rise. This is why we're also monitoring the hospitalization rates and the rates, the occupancy in intensive care units. So we have done rapid risk assessments. We did the first one in January, where almost nothing was known, except that it was a novel coronavirus. And we will publish our 12th update tomorrow. We did these risk assessments whenever the risk was changing, whenever there were new facts becoming known, like asymptomatic infection. We presented the non-pharmaceutical intervention set that was then used in March, April for the lockdowns. We presented then also what should be done when you start lifting the lockdown. We monitored now the situation in the summer, and in beginning of August we had the first one where we said, well, there's an increase, and the increase hasn't stopped since. The next area I would like to show is guidance. We have produced a multitude of guidance documents for our core areas, meaning surveillance and everything involved, for laboratory tests, for monitoring and evaluation framework, infection prevention control guidance in various settings, long-term care facilities, hospitals, primary care, with all facets, personal protective equipment, disinfection, and so forth. We have for specific settings like school, how to go about population-wide testing. We have projected baselines published in June, and another set recently, how to conduct in and after action reviews in order to monitor and see what you can improve. We have provided guidance on traveling and many more. Speaking of, so that is the monitoring and evaluation framework that follows really the comprehensive view and a set of indicators to capture how the current response in the country is set up, and whether there are improvements to be made, and whether this is set up in a way that increases can be detected and the effectiveness of measures can be evaluated. Now, coming back to the traveling, this is, of course, an area where there is very different approaches in the EU. Now, we had tried, especially in the phase in May, when countries reopened, traveling was supposed to resume, together with our colleagues from the European Aviation Safety Agency, to come up with guidelines for the management of air passengers and aviation personnel. These guidelines cover the whole trip and were aimed at a uniform implementation. Then, of course, there are other modes of transportation that opened, like the railway and the cruise ships. And we also published infographics that made it really easy what travelers should be doing. Now, the current situation as regards testing and travelers is that EU member states have very different requirements, which make travel really confusing and prevent a lot of people from actually traveling. So most countries that require a negative test, either pre-departure or upon arrival, use RT-PCR tests. But they have various requirements. Like in some countries, it's necessary that you do take the test 48 hours before departure. In other countries, you can do it 72 hours. And while the RT-PCR is a very accurate diagnostic test, it takes some time to receive the results. Moreover, it only represents a snapshot of the person at the time of the testing. So especially for asymptomatic people, it cannot also differentiate between infectious and non-infectious people. Now there are new antigen tests in the market, and some countries are exploring their use. But we also have to see, of course, that travelers are have a prevalence magnitude lower than contact persons of known cases or actually symptomatic persons. So there are still issues that need to be validated. Then we come to quarantine. There are also different measures, because some countries use it for all incoming travelers. Some countries use it for incoming travelers only from certain zones, regions, and countries that periodically and sometimes frequently change. And there are combinations of quarantine and testing. And moreover, sometimes the quarantine periods vary. So some countries do it 14 days and some countries do it 10 days, or sometimes even only 7 days. So our assessment is that travel restrictions can delay the transmission if they are implemented comprehensively and strict for all areas with virus transmission, and if there is no or extremely low domestic transmission of the virus. We would consider that these conditions can most likely only be implemented in islands, in smaller islands. So once domestic transmission is ongoing, the contribution of the imported cases will be extremely limited compared to what's going on in the country. And since these travel restrictions require resources in, of course, material and staff, they can take away and divert use of public resources from the control of the epidemic in the country. So our position is at the current epidemiological situation that I have shown you. ECDC does not suggest measures at the borders as an effective and efficient way of reducing the transmission. That may, of course, change once the case number would diminish to very low levels. What we suggest is to be done is that the public health services at all levels in the country should be strengthened and supported equally for travelers and citizens of the country. And in particular, the contact tracing capacities really need to be established. So what we're doing right now is we're working with the IPCR. That is the Inter-Policy Crisis Response Instrument of the European Council, to implement the proposal for a Council recommendation on a coordinated approach. We do also internal modeling to find solutions. We work with the agencies and parts of the Commission that deal with these travels. And we are contributing to international discussion with the organizations involved in international travel. The other issue where there is a marked difference how countries have implemented is masks. So the current policies in the EU, which, by the way, you can look at, because we are actually monitoring at which point which measures are in place in which country. So currently, mask use is in some countries voluntary, in some countries mandatory. In some countries, it's nationwide. In some countries, it's only locally. In some countries, it's for indoor public spaces in general. Some countries add public transport. Some countries, it's all public spaces. Some countries, it's the workplace or specific occupation. So given all these possibilities, it's no wonder that when asked whether they have worn a mask outside their home, beginning of August, the people in countries responded very, very differently. So the dark violet is here that they wear the masks always, and this pinkish is never, not at all. And the main determining factor here is whether it is mandatory or not. So, but what is the evidence? There are different settings that have been looked at. One is high transmission settings, households, colleges, healthcare, and it's only a small number of studies outside of healthcare. Small protective or no effect has been shown. But the caveat is that these studies are often so small that the power to detect any efficiency may not have been there. They have sometimes inappropriate control groups used. The adherence to the face mask wearing was not there. And most evidence comes from influenza that has a slightly different transmission anyway. So basic science experimental studies were another source. So there were medical and some also non-medical face masks used. They filter a large proportion of respiratory droplets and decrease the amount of expelled droplets, but it's indirect evidence here. So then there were some experiments that introduction of face masks used in populations have been linked to decreased COVID-19 incidence. There are examples in Germany, in various states of the US, but also in Asia. But here it cannot be excluded that there was an effect of other concurrent measures. So there were also arguments saying, well, there's a face mask shortage, which at one point was the case. But then at that time, medical face masks have been prioritized for use in healthcare, and non-medical face masks have been used. And now there is also an increased availability. The other argument was wearing a face mask may create a false sense of security. That has not been supported by data. The use of protection measures has been associated with less risky behavior and better compliance with other measures, actually. Then the last argument was that improper use may lead to increased risk of infection. That also hasn't been supported of data, and it may actually even help reducing that mouth and nose are touched incidentally. There has been a study looked at the effectiveness of non-pharmaceutical interventions against COVID-19 in 41 countries, where face mask was one, and the mandatory use of face masks in the public had a very small and non-significant effect, but at the same period, countries have already implemented, as said before, other distancing measures. So it's very difficult to assess these days what effectiveness face mask as the sole measure would have, and we are actually not recommending this. So we also say that in principle, face masks should be used when the physical distancing cannot be guaranteed. So they are basically an additional measures. Just here as a side thing, the use of gloves in the community is discouraged from our side. There's no evidence for a protective effect. It's recommended only for persons that are caring for COVID-19 cases, because it might lead to neglect hand hygiene, has skin side effects, and generates an enormous amount of waste. So in terms of communication, here, we in ECDC have seen an unprecedented increase in requests, also from areas that never had an interest in ECDC or had us on our radar, like The Economist, The Guardian, Le Monde, Washington Post, and the Wall Street Journal. We have, in addition to our guidance documents to our social media presence, provided material for educational campaigns, in particular to be used for the population, using face masks properly, especially on gloves, that it shouldn't be used. These are the infographics that we have used for the aviation. And then we had already from 3 national parliament inquiry committees really requests regarding when did you publish this one? When did the countries know? When did this minister visit you? So in order to actually prevent us from going back to our documents every time, we have now produced a guide, a timeline that is published, where from the very beginning, the first case, we have listed all our outputs, all what we have produced in this timeline that you can slide, that you find on every day, for every measure that we have produced, for every document. You can go online and read it, and you find all of them there. So basically, that is the most comprehensive part that we have, a comprehensive overview of our products since the beginning. So I go back to. So I have to move this.
So Andrea, thank you very much. Just a quick intermezzo. The session will be ending in 4 minutes. So if you could wrap up in the next 2 minutes, that we would have time for questions. Another just for 2 minutes. That would be.
It was short anyway. So support to stakeholders. We did a lot of stakeholders support directly, indirectly. We have for specific areas, specific support mechanisms. And I just wanted to show that compared to our usual partners and stakeholders, we have now been cooperating with a lot more, with different areas, just showing also how far COVID reached. We have also increased our international presence. So the outlook. We were often asked regarding influenza. We don't have an experience when influenza and COVID are co-circulating, because it was already on its way out. We are in the process of, together with WHO Europe, to provide surveillance documents to monitor actually influenza and SARS-CoV in the winter simultaneously, and keep track of it. So there is some forward-looking guidance, and this is basically where you find our daily updates on the dashboard, and the country overview if you want to know what the situation in every country is. Thank you very much.
Thank you so much, Andrea, for this beautiful presentation. At this time, I would also like to welcome my co-chair, Giacomo Girard. If you have additional questions to Andrea, please state them online so that we could ask them. I currently do not see any questions. While I'm monitoring this, Jakob, I will hand over to you to start with the first question, and I will look at the questions of the audience.
Thank you, Annelies. Hi, Andrea. Thank you really for this splendid talk, and thank you for being with us in this unusual scientific event. And my question to you, I mean, many people are speaking about the broader public health impact of COVID-19 beyond the mere infections, mental health, non-communicable diseases, cancer screening and prevention that may be disrupted, and so forth. And I wonder, what is your view on a European scale on how we can do surveillance and monitor the broader health impact of this pandemic?
Yeah, I have. Thank you, Jakob, for the question. I have also replied to this question many times, that unfortunately right now our mandate covers only infectious diseases. So we cannot, even not only in the health area, assess the full impact of COVID. We can do it for infectious diseases, but as you say, the ramifications of this pandemic go far beyond this. And I would also, that's my personal opinion, see that when we now look into how the preparedness of countries, especially the preparedness in health, can be increased and improved, that we also need to define, based on this experience now, certain essential health services that should not be closed until the very, very last moment because of the long-term consequences.
Many thanks, Andrea. Many thanks also to Jakob. I did not receive additional questions from the audience. And with this, I would like to wrap up this beautiful keynote session. Now, just one came in. Can you recommend where to read more about the protection of different face masks? This would be the last question before we're heading over to the fireplace session. Thank you, Andrea.
Yes, I mean, we have actually produced a specific guidance, a document, not only the infographic or the video on face mask, where we explain the differences between an FFP3 and FFP2 surgical face mask and the non-medical face masks, the face coverings, and also how they should be used. So you find this on our website. It now may be a bit hidden, so maybe use the search function or the time slider that I have shown.
Many thanks. Thanks to everybody for joining in these difficult times, and thank you, Andrea Ammon, for this beautiful talk. Goodbye, everybody.
Thank you for the moderation.
Thank you very much.